Should we start, sir?
दादू पण झोपलात काय दादू?
Requesting everybody to mute, please. Okay, so a very good evening, and on behalf of IIP Mumbai, I welcome you all to this very appreciated and liked program of our Webflix series. This is the season 2 and episode 2 of the year 2024. We had one last month, which was on gastroenterology, and this month, as we all know, is going to be on pediatric rheumatology. So I think all of us agree as practicing general pediatricians that pediatric rheumatology is not as simple and easy as it seems all the time. It is a disease in evolution, and nonetheless, it's not very uncommon because the incidence from different studies reported in India is as much as 1 in 1,000 children. So, because you may just not have a connective tissue, you may have a lot of multisystemic affection. The labs always are very perplexing. It always evolves. So, we are never sure that a time a child comes to us in an OPD at presentation, whether he is going to evolve into a connective tissue and whether we need to really pursue. I mean, there are a lot of questions and a lot of doubts regarding this. And to solve all this, we have none other than our IIP Mumbai secretary, Dr. Sikha Agarwal, as the expert today. So, Sikha is a pediatric rheumatologist who's attached to the Hinduja, Nanavati, and Surya Hospital in the western suburbs. And she has a private clinic at Vile Parla, which goes by the name PrEP, which is pediatric rheumatology. So, welcome, Dr. Sikha. And I'm sure today at the end of the session, everybody is going to take home very good key messages to keep in mind as far as pediatric rheumatology is concerned. And to moderate the session today, we have none other than always smiling and chirpy and dynamic, our EB member, Dr. Jagruti. So, without much ado, I think we'll start with this session. And I think over to both of you.
Yeah, thank you so much,
again,
Dr. Nehal.
Sorry. So this is again going to be like an open house, as all of us know who've been joining Webflix. So we will really encourage and invite questions at any time regarding any topics that are going to come up. Please put them in the chat box and they will be taken up by the moderator from time to time. Thank you.
Yeah. Good evening, everyone. This particular Webflix does not have an MMC points, right, Dr. Nehal? So I would request people not to put in their numbers because I think that will interfere with the questions that will come in. So we do not get MMC points from these Webflix, but it will enhance our knowledge to know levels. I will be very glad if people can put their questions on their chat box, and we'll be very happy to take them up as and when we are able to talk and ask Dr. Sikha about the same. I would start with a quote that says that ask 5 different rheumatologists and you will get 5 different diagnoses, probably 6 if one of them is bred in Harvard. And we have Dr. Sikha, who is bred in our Indian Harvard, that is PGI Chandigarh. And she will be able to probably tell us all possible diagnoses that we can think about as practicing pediatricians in pediatric rheumatology. Of course, at the end of it, the bottom line still stays that we can refer our patients to pediatric rheumatologists. But having said that, in the first instance, when a patient comes to us, to actually recognize it to be a pediatric endocrinology case, pediatric rheumatology case itself is a big thing in itself. So to start with, I would ask Dr. Sikha that in a patient, when do you suspect rheumatic disease or when would you not suspect? I mean, what are the pointers that would say that this could be a patient who could have a rheumatic disease or a connective tissue disorder?
Thank you, Jagruti ma'am, and thank you, Nehal ma'am, for such a kind introduction. So we'll directly go to the question that you asked. So what I understand is rheumatic disorders is like wide spectrum of disorders. We can have the group of arthritis, we can have vasculitis, we can have autoimmune disorders like lupus and chronic disorders as well. We can have acute disorders. So if you ask me what is one or few signs and symptoms to say what a rheumatic disease or this child can have a rheumatic disease is like, you have to open a Pandora's box and tell all the symptoms like acute can have this and chronic can have this. So as we have always been taught, it's the clinical thing that we pick up. Okay, this might be a pain or swelling of a joint, might be an arthritis. It can be an acute also, it can be a chronic disease also. Similarly, if you're seeing an oral ulcer, it can be a rheumatological condition. So what I usually feel कि जब कुछ समझ नहीं आ रहा है तो think of rheumatology. If you feel the common things which we are thinking of and उससे बच्चा treat नहीं हो रहा है, ठीक नहीं हो रहा है, and the symptoms are there, or symptoms are very severe, or symptoms are very catastrophic in certain cases, then think of rheumatological disorders.
So do we, like in practice, we do come across patients with fever, arthralgia, and rash, very commonly seen. Do we think of all these conditions as rheumatic disorders? Could they all
No.
progress?
Yes, so no. So common is always common. So first is always the viral illnesses which you consider, which can come with fever, rash, and joint pains. So you always consider, and the first 2 to 3 days when the child is kind of stable, and you even if you diagnose a rheumatological condition, you would not act immediately, right? So in that case, you wait and watch. You wait and watch how the child is behaving, and you don't even investigate. You don't even do any labs at that point of time. And if on the follow-up, if you see fourth or fifth day, the clinical cues are changing, and you feel that something beyond a viral thing is considered here, that is the point when you would consider there might be a rheumatological condition.
So important thing is to follow up these patients. But so many times we as physicians might confuse, especially in heavy OPDs, between arthralgia and arthritis. So do we need to distinguish between the two before we think of it as rheumatic? And how would you distinguish?
So not rheumatic. For arthritis diagnosis, you need to distinguish. Arthralgia, in rheumatological purview, there are a lot of diseases which can have just arthralgia. But in an OPD basis, you need to differentiate whether you are dealing with arthralgia or arthritis. So arthralgia is just pain, joint pain. But when you examine, there is no swelling of the joint. So any signs of inflammation where you feel there is a redness of the joint or warmth over the joint or any other sign of inflammation or a swelling or a significant restriction in joint movement. So I put a rider to restriction in joint movement because with pain also, sometimes a small child will not allow you to move that joint properly. So joint pain is arthralgia if there are signs of inflammation or if there is a chronic deformity where there is a significant restriction in movements, then that is arthritis. And of course, you need to differentiate because even in the rheumatology armamentarium, the diagnosis or differential diagnosis would change.
Okay. So Dr. Amit Devkar is asking that when are oral ulcers red flags? And which characteristics of oral ulcers on examination will indicate a rheumatic disease?
Okay. So oral ulcers, if I consider, if the child is coming with a painful oral ulcer, see, they can, again, in rheumatology, we can deal with patients who can be like a periodic fever with oral ulcers. Like they are having symptoms every monthly and they come just with oral ulcers. One is that. If you, madam, is considering that if there is a chronic ulcer where there is no pain and you examine and you see there is an oral ulcer, so that can be more likely in patients with lupus where there is a palatal ulcer which we get, but the patient is not complaining of that much pain. Whereas as when we see the signs, we see it seems to be a very significant oral ulcer that we can see. Vis-a-vis if you have vasculitic disorders, then for example, Behçet's disease. So they will have recurrent oral ulcers, but they will have persistent fever in between and they will be not so well growing child. So that is another diagnosis. So again, with oral ulcers, common things first. So if you have a child who have a bit of B12 deficiency or something else, so usually as pediatricians, we always treat that. And when it doesn't get treated, the commonest is recurrent aphthous ulcers again, which again, we see a lot of patients with recurrent aphthous ulcers who may need immunomodulatory treatment also. And if not that, then you think of all these disorders which can be there. Then you investigate accordingly.
So what immunomodulatory treatment for recurrent aphthous ulcers would you recommend?
So it all depends on the patient. So if there is something in which see 2 to 3 days after ulcers, which doesn't affect the school, which doesn't affect the daily life of the child, we would just counsel, give topical treatments. But if there is something where there is sometimes I've seen patients who have school absenteeism for 4 to 5 days, and then there is a lot of problem. Mother is concerned the child is not gaining weight because that child is not eating properly during that time, then colchicine is the best one.
Okay. Okay. Right. So that, yeah, that's clear. Thank you, Dr. Sikha. Coming to, let's talk about one of the most common rheumatic diseases that we see in practice, that is juvenile idiopathic arthritis. And eventually we'll also talk about Kawasaki's disease. But coming to JIA, there is always a confusion in the type of classifications. With every new Nelson, we see a new classification of GIA. So can you give us some clarification on what is the latest classification and how would that classification help us in the management of a patient whom we suspect to be a GIA?
So to be very frank, the classifications are changing so much. So you're very correct that it's changed. So 2023, the recent classification by Printo has appeared, which we now tend to follow more frequently, in which we are not dividing it as per the number of joints involved. We always knew that oligoarthritis, polyarthritis, very easy for us also as rheumatologists to remember the number of joint, 5 hai, 5 se kam hai. So you classify it. Now, what they have suggested the classification is one, early onset ANA positive juvenile idiopathic arthritis. So the name itself indicates early onset, less than 6 years child. Of course, chronic arthritis has to be more than 6 weeks of arthritis. ANA positive disease. Second, RF positive arthritis. So they have not classified poly or oligo to count the number of joints because it's over a progression. So a lot of times later you find that the child has more joints. So RF positive arthritis. Then you have systemic arthritis, easy, and enthesitis related arthritis, which again we have had in the previous classification, and the rest all are put in the others category. So there are just 5 classification to be very easy. The other one had the initial which we followed used to have 7 classifications.
So then does it mean that for every patient whom we think of as JIA, we must to start off do investigations like ANA, RA factor and all, and whether that would confuse our diagnosis at times because sometimes you could have false positivity for patients who come with us with say fever and arthralgia. And if that is thought of for a shorter period than 6 weeks, then when would you in the course of the illness do investigations like ANA and RA factor, and whether there are these investigation panel, rheumatic disease panel, which so commonly is used, and whether they would in fact help or hamper our diagnosis.
So one thing is very clear, whether it's we are dealing with a pediatric case or any other case, we do not do panel investigations because even if the labs have created a panel, they are more adult oriented. So every lab which has a panel will have a uric acid level, which is not at all important in a pediatric case. So this is not advisable. Second thing, when you were asking fever with arthralgia, until unless you're thinking of systemic GI with arthralgia, you will not investigate only because they don't have arthritis. So if there is an arthritis, if we are following the previous classification or this classification doesn't matter, we do basic inflammatory parameters for all and ANA for all the patients. That's very important. That's highly differentiated from the adult onset. So adult people will not do it. In pediatric age group, it's very important to do an ANA positive ANA test because like in the classification itself, they have added now. So the early onset, if there is an ANA positive disease, then they tend to be more severe. The chance of uveitis may be higher in these patients. So that is very important to do an ANA positive. Initially, what we used to do, and still maybe I still follow that, if there is a polyarticular involvement, more than 5 joint or small joint involvement, then I tend to do more RF. This classification has not clearly defined whether you should do RF in all or not. So we never, still I don't practice that doing RF in all. If I see more joint involvement, then I do an RF. And RF is not a diagnostic. Again, it's a clinical diagnosis. Like you said, confusing the diagnosis, even if AN is negative, even if RF is negative, your diagnosis doesn't change. Your prognosis may change. Your classification may change, but the diagnosis will not change.
Mm-hmm. So then in that case, Dr. Sikha, when we do this ANA test, is there a way by with the methodology of ANA test done in the labs, does that make any difference? I mean, there are some people who say you have to do it by the immunofluorescence method or by... So
So screening test, immunofluorescence, so you want all whatever antibodies ANA के हैं वो सब आपको pick up हो जाने चाहिए. You're not doing any specific like anti-Smith or anti-dsDNA. Specific we do by ELISA. So in this we do it by IF method. Of course, IF is a bit costlier method. So if you go with government hospitals, they more frequently give us ELISA. But now most of the government hospitals also started doing immunofluorescence method ANA as well.
Okay. Just let me see. And what if there is initially just a single joint involved to start with? Like, I mean, the patient may come to us with the first joint involvement. At such a point of time, if somebody has done a ANA and it has come positive, okay, but Normally, as pediatricians, one joint involvement, monoarthritis, we would like to think of it as viral. If it is really very like, high fever and all, we would think of it as septic. And then as if it progresses, only then we would think of something like a GIA. So doing early ANA would hamper our diagnosis, or it would help us to look into it from a long-term perspective.
So see, early we do, JI is chronic disease. More than 6 weeks is by definition, but at least more than 4 to 5 weeks, you start thinking that it is JI. If it's an acute arthritis, for example, we deal with reactive arthritis or acute rheumatic fever or any other acute arthritis, post-viral arthritis, with whatever it is, which is actually reactive, you don't do an ANA because there's no point doing an ANA here. And a septic, of course, infection itna hai, wo bacha will be very sick, fever will be high grade, and there'll be a joint which will be in 2 to 3 days getting involved. You don't do any because that will be 1 plus 2 plus, which can be false positive. Any infection can give to a rise of antibodies, increase in antibodies, and ANA can be positive. So you don't do any ANA. It is only when you are thinking of juvenile idiopathic arthritis, the child is persistently symptomatic for 4 to 6 weeks. It's such a gradual disease now that initially parents always feel कि बच्चे को चोट लग गई है, गिर गया है. They will not come to you only for a lot of things. They will never come to you कि बच्चे को problem है. And initial stage में अगर if there is also, then you will always think maybe it is reactive to something else, maybe it is trauma, or maybe after a viral. And then once it progresses, then you start investigating further.
So, Dr. Sikha, oligoarthritis, I mean, still your treatment, like your first line of treatment would be guided initially by the number of joints only, it's not guided by the ANA or by the ANA positivity or not. So how would you now, with this new classification, say if you have a child who has come with 3 joint involvement and it is ANA positive, what would be your line of action?
It all depends that. See, normally 1 or 2 joint involvement, we inject. Whether we are diagnosing as RF positive disease or we are diagnosing as RF negative disease or whatever diagnosis we are giving to the child, the best line of treatment, like we follow everywhere, topical is, अगर topical काम करेगा, मतलब तो systemic नहीं देना है. So if it's a local injection that we can give, and if we feel that can work, then we should go with the local injection only, intra-articular injection. So 1 or 2 joints, joint accessibility. So if there are smaller joints, though these can also be injected, but the smaller joints you will not try to inject. You know this child will need a systemic therapy. So like the first question, I think I missed the monoarticular joint that you were asking, when there is a single joint. So in juvenile idiopathic arthritis, the oligo variety, whatever we had the initial classification, mono is the commonest one. Of course, that's the most confusing one because chronic infections like tuberculosis is a very important differential diagnosis for monoarthritis. But then there'll be other telltale signs, and tuberculosis, when it is a osteoarticular TB, it eats up the joint very early. So you will have more damage. So if you are doing an imaging, the cortical erosions, the damage, the fluid will not be that clear. So all these things will be there in tubercular infection of a joint. And then you differentiate it. If sometimes we go ahead with a joint biopsy when we are really confused whether it is monoarticular tuberculosis, osteoarticular, or are we dealing with JI. Then once we prove it that it is not tuberculosis, then we go ahead because what we are injecting is steroid. And if it is tuberculosis, that will harm more.
Right, right. So when you have with your ANA positive oligoarthritis, suppose if it's treated with intraarticular steroids, the ANA positive itself will give us some indication towards a bad prognosis, especially for ophthal case. I mean, uveitis and all.
Yes, yes.
So how often do you do this ophthal examination follow-ups?
So ANA positive, ideally, it should be done 3 monthly. But at least 6 monthly, we have to do a uveitis checkup. Why? Because the first thing is chronic. It is a chronic, and it is a chronic anterior uveitis with no symptoms in the initial stages. The vision loss also, which happens is like later on when there is a synecdoche formation or something like that. That is the stage when the child will have vision loss. So we tell कि एक बार मेरे पास मत आना, but वो ophthal follow-up जरूर करना है आपको, because to us they will always come symptomatic, they will come only, but to ophthal they will not go because they always question us कि अरे joint में problem है, why are you screening, मतलब why are you even sending us to a eye specialist. So we'll have to counsel them that you need to visit the eye specialist.
Okay. And does CBC help? Like, so many times people, like when a patient comes, for example, in systemic onset GIA, patients will come with fever, may come with a rash, will come with generalized, signs and symptoms. So in such patients, does a CBC help in the diagnosis, or sometimes, even patients like say Luke's and all may present like that. So how do you differentiate at times between a systemic onset GIA and a leukemia patient, and how would you go about further? Because that's very important to rule out, right? Because sometimes you might be wanting to use steroids.
Systemic onset GIA is a diagnosis of exclusion. The first thing, you exclude everything, then you think of it. So now the recent classification has also omitted arthritis as a compulsory part of diagnosing systemic GIA, making it easy for us to diagnose systemic GIA. But we all know that we really need to investigate these children. Systemic onset GIA is something which will need steroid for a longer duration, vis-a-vis any arthritis which doesn't need steroid, or if it all requires, it requires for a shorter duration. So in this case, first, of course, CBC, very helpful. So platelet count, whether it is normal, high or low. CBC, which is showing a lymphopredominance. So if there is a lymphocytic predominance, then of course you think leukemia. But for me, even if it is a neutrophilic predominance, you should always do a peripheral smear, because we all have seen patients with normal platelet count, neutrophilic predominance to be who turn out to be leukemia, acute leukemia. Very close differential in patients with systemic GI. Usually, if you see clinically now, you will see that patient is more sick in case of leukemia. In the systemic GI, between the fever spikes, the child is absolutely fine playing around. So small clinical cues you have to pick up, lab cues which are there, triple figure ESR, that is again pointer towards the possibility of more chances of leuk, of course, and then you try and do a marrow before you start a steroid in these patients.
Okay. Fine. I'll just look into the chat box. Okay. We also talk about, I'm going a little faster now towards, okay, from a faster because I want to also cover up other topics. So ESR and CRP, during the treatment, what helps us to guide for monitoring the patients in GIA? That's one question that I wanted to ask. And then, of course, the big Pandora's box of biologics in GIA. If you could elaborate on these two.
Okay, so for ESR and CRP, we actually do both initially. And then the CRP is one thing which falls very rapidly. So it'll, once you start off the treatment, around 4 to 6 weeks, with an adequate treatment, if the child is responding, the CRP will come down to normal, and ESR will take a longer duration to come down to normal. But ESR a lot of confounding factors as well. So simple anemia thing can also cause a ESR to be high. So you have to see in the light of other investigations as well, that how it goes. Okay, coming to the second question of biologics, let's not go into the nomenclature. It's like huge, then we'll have to see everything. But biologics, definitely, if you're talking of JIA here, anti-TNF, and they have changed the prognosis, they have changed the way we used to look at arthritis, कि अभी क्या होगा, बच्चे को first line से response नहीं आ रहा है, second line से response नहीं आ रहा है, so what should we do next? But now, the anti-TNF molecules that are available, adalimumab, etanercept, all these, infliximab, and especially these are subcutaneous injection, no requirement of admission also. So definitely they are very good molecules, anti-TNF, for the treatment of JIA, except systemic. So systemic is more of an innate immune system which is involved. So we have to use an anti-IL-1, anakinra, which is not available in India. It's like beyond very costly therapy if you procure from outside. Then we tend to use the anti-IL-6, tocilizumab, which has been made famous by COVID.
Okay, yes. So any contraindications for using biologics? I mean, in general, are there any?
So we always screen for tuberculosis in this patient. See, and ultimately these all are immunosuppression. So in all the DMARDs we use or steroid we use, we tend to use, we see whether there is any infection underlying or not. And then tuberculosis is one thing in India, we always look at it, whether they are having a latent TB infection also. We treat that latent TB as well. But you can give the biologics. Then, of course, the liver parameters, the kidney parameters, those should be okay with before we give all these medications.
And how long does treatment last? Is it like a lifelong kind of treatment, or do they have periods of remission and you follow up them during this period, and again they would relapse or something?
Every child, whatever treatment it is, 2 years in remission. So 2 years in remission is the time after which we tend to taper it and stop it. So that only to reduce the recurrence rate. So what has been studied is like if the recurrence rate is higher if you stop earlier. So we have certain patients who have been treated outside and they after 3 months, like they respond well and then immediately the treatment is stopped. Then that doesn't work. Then it has the chances of relapse are high. So 2 years in
So two
remission is
years.
usually
Okay.
different for different disorders, but for GI usually.
Okay. I think we have kind of, one important question I wanted to ask was diet in patients of GI. Like as private pediatricians, practitioners, they would come to us saying ki kya khana chahiye. So what are the things that you would ask the parents to avoid in diet, or things which you should ask the child to eat?
Okay, so one very important myth is खट्टे से मतलब आंबट खाल्ला तर arthritis होतो, but that has not never been proved medically that there is a chances of increase of arthritis with any sour items also. What we need to be consider is whether the child is on steroid or not. If the child is on steroid, for example, systemic GI, then of course, as per the steroid doses, we tell them, because there'll be a weight gain and there'll be chance of other things. So we'll tell them salt retention and also reduce the salts, reduce sugar, and maintain the weight. Accordingly, we will advise, or also intermittent feeds में आप क्या दे सकते हो when the child is actually hungry. So the child will ask for food. So that is with the steroid. Otherwise, there is no specific diet. A good healthy lifestyle balanced with good protein in the diet is advised. So
Yes.
another thing, what people that these children should have a bed rest and they should lie down on the bed and not do the normal activities. But this is absolutely ulta. They should actually have normal activities.
Can they take part in sports and all?
Yes, absolutely. Until unless you're seeing significant arthritis where you're expecting an impending fracture, that's separate. But otherwise, if the child is well, the child is in remission, or even initial phase also, we advise light physiotherapy and then more active physiotherapy, and all sports they can take part. No contact sports avoiding or something, because they don't have a tendency to bleed or something.
Okay, that's good. Okay, I think we will move on to Kawasaki's disease now, and I'm sure there'll be many more questions that will come up on that. Kawasaki's, as we started off, like during residency, we barely saw cases, and now there are more and more people who are aware about Kawasaki's disease. And now we talk more and more about incomplete Kawasaki disease. Like we know the typical features of Kawasaki's, like where we have fever for more than 5 days and all the other criteria, 4 out of 5. But what do you mean by incomplete Kawasaki's, and do we really see many such cases in India? And if there are any other variants that we should be aware of?
So of course, incomplete Kawasaki disease, we see a lot of cases in India as well. And they can be like, the only thing is when they're not fitting into the criteria, like we say fever for more than 5 days and 4 of the following criteria. If they do not fit and we're still considering that they can be Kawasaki, that is incomplete Kawasaki, where we diagnose it. The labs and the echo findings usually help us in these cases where there is an incomplete Kawasaki disease. So if there is inflammatory parameters which are high, we rule out that there are no other infective focus. That is the time we consider that the child might have incomplete Kawasaki disease. Other things which we look when there is an incomplete Kawasaki, we can see a BCG site, especially if the child is less than 1 year. There might be a reaction at the BCG site. That is one thing. Then perianal area. Perianal area can have a peeling of the perianal area can happen in the first week of the illness, which can happen both the complete and incomplete Kawasaki disease. So these things we'll tend to look at in a case when we're suspecting Kawasaki disease and an incomplete Kawasaki disease.
So Dr. Kasla is asking that what investigation would you suggest in a case of a pyrexia of unknown origin where infections are ruled out and there are no clinical clues towards autoimmune disorders?
Okay, so see, like we discussed, first, even if the child is of pyrexia origin, as a pediatrician, we would always do a CBC. So first, we try to figure out are there clues in that CBC. Supposedly, we see that everything seems to be normal. Second, we see C-reactive protein and ESR also. So if there is an autoimmune disorder, the C-reactive protein is usually normal to the proportion of fever that the child is having. And the ESR is disproportionately high. Usually CRP and ESR are something which go hand in hand. So CRP बढ़ा तो ESR भी बढ़ जाएगा. But sometimes in autoimmune disorders, especially with lupus or dermatomyositis, where they may not have typical rash, typical oral ulcer, they may just have fever. And then the CRP will be towards normal, like not 6, if 6 is the normal range, 6 or 7, and the ESR will be like 90, 80, something like that. So one other clues here. Then we do a simple biochemistry. If we see, then there will be an AG reversal. So the total albumin to globulin level. So there will be an AG reversal, which we can see in these patients. So simple clues, maybe slight elevation of LFT can be done. If there is some weakness of the child, then of course we'll do a CPK total where the muscle enzymes might get elevated. So these are clues which will tell us that yes, we need to investigate further these kids for an autoimmune illness, like ANA or things beyond that has to be done.
So coming back to Kawasaki's, in the first week of the illness, do sterile pyuria help in our diagnosis, or it's just another finding?
So I'm not sure about the first week of the illness. Yes, the infant kids have more chances of sterile pyuria. So urethritis or small amount of renal injury in Kawasaki disease can cause sterile pyuria. And again, like all these syndromes have been knit pieces together, join the beads together, and finally lead to a diagnosis. So similar is Kawasaki disease. No single test can tell you that this is Kawasaki. When you knit it together and you feel, yes, sterile pyuria is there, yes, fever has been there for so long, yes, there is a rash, or yes, there has been a history of red eye. Sometimes you may not see the child with a red eye. There may just be a history because these are symptoms which last only sometimes for a day or two. By that time, you might not see, some other pediatrician must have seen. So that way, you knit it together and think that it is Kawasaki disease.
And what about eco and Z-score based system in eco and Kawasaki? Can you just tell us a little bit about it as to how does it, like how often should you do that to help us in the prognosis of the patient?
So echo, first thing, it's a clinical diagnosis. So it's not a diagnostic value, but of course, very, very important because cardiac system is the most important where we know that it gets affected with Kawasaki disease and early treatment is required. So Z-scores are the commonest, and when we send it to a pediatric cardiologist, they always send with the Z-score if you tell them that we are looking at the coronaries and Kawasaki suspected. So if it's less than 2.5 Z-score, then there's just a dilatation, 2.5 to 5, 5 to 10, and more than 10. So accordingly, these scores are classified to classify the patient as mild, moderate, and severe dilatation. So of course, these also guide us to therapy of the child. So now there is a recommendation of doing primary intensification. So if you suspect Kawasaki disease, you do a 2D echo, you find a dilatation. Then besides IVIG, you can do a primary intensification of the therapy, especially if the child is younger age group. So primary intensification means you will not only give IVIG, but you will give some other immunosuppressive along with it as well, which can be either steroids or it can be infliximab, depending on the affordability rate.
Okay,
Yes, and of course,
I thought we
with
used it only for those resistant cases of the ones which, like, so Dr. Reepa Agarwal is asking that what biologic do you prefer in an IVIG resistant Kawasaki disease?
anti-TNF. Infliximab is the recommended thing. IVIG resistant disease means you will use infliximab in these patients.
And that's like a single dose, or it is given over a period of, what is the dose?
So it's an infusion, single dose infusion. So sometimes if not affordable, you use steroids.
So Dr. Khernar is asking ki low dose or high dose aspirin for Kawasaki disease.
Initially 48 hours till there is fever, you use an anti-inflammatory dose. Initially we used to recommend 80 to 100, but now it's 30 to 50 milligram per kg per day. In divided doses, aspirin is used. And once the child is febrile for 48 hours, then you shift it to an antiplatelet dose. The antiplatelet dose, at least for 6 weeks, it will go only. And if the echo is showing dilatation persistent, it may go longer also. So antiplatelet dose is 3 to 5 milligram per kg per day.
And while a patient is on aspirin or while the patient is on any of the biologics that we have been talking about, or in the previous condition, DM ARDs, how does the vaccination protocols change?
So vaccination, first is if there is IVIG which has been given, you have given antibodies, so you do not vaccinate. There are very haphazard recommendations on that. Some will say 11 months, some will say 6 months, some will say 3 months, but at least 5 to 6 months we say do not vaccinate because your vaccination will not work. Okay, so this is the time when the child is on aspirin as well. When the child is on DMARD, in fact, the contrary, what we think the child needs less vaccination, the child needs more vaccination because he's an immunosuppressed patient. He needs more vaccination. So whenever the primary pediatrician, we are always in liaison with the primary pediatrician, we always say once the steroid dose is reduced to 20 less than 20 milligrams, then the child should receive all the optional vaccines also. Especially they are more prone to develop influenza, pneumococcal infection. So they need those vaccination all the more. Yeah, aspirin, like you said, we are concerned about giving varicella vaccine, Ray's syndrome. So by that time in Kawasaki, you have a decision also whether the aspirin has to go off or not. Otherwise, you'll have to stop that aspirin for 6 weeks or so and then vaccinate and then restart if required.
Dr. Bharti Khairnar is also asking that how can we predict IVIG resistance in a child with Kawasaki disease and how can we do that?
So there are certain parameters or there are certain guidelines, not guidelines, certain people have recommended things where they can predict. So usually if a child is younger in age group, a typical Kawasaki disease, like we call incomplete Kawasaki disease, if there is thrombocytopenia in the first week of illness, if there is significant hyponatremia or if the LFTs are significantly deranged, there are certain things which tell us that the chances of IVIG resistance is high. But of course, we always monitor these children as other children as well. And if the child is a recurrence of fever or the fever is not resolving after 36 to 48 hours of the first dose of IVIG, then we consider it is resistant and we hike up the therapy.
But you will still give IVIG in these patients to start off, right?
Yes, yes. Like I said, primary intensification nahi kiya hai. The child is only just Kawasaki, no primary intensification not done. So we'll give with IVIG only, aspirin plus IVIG. And then we will, it turns out to be resistant, then we add on to the therapy.
Okay. So there are a couple of questions on the chat box about this. What about live vaccine? Should we avoid in patients on treatment with methotrexate or on biologics?
No. Live vaccines can be given to these patients also. On methotrexate in this, they can be given. Steroid is the more of a guide to tell us कि if you are seeing, मतलब practically if you're foreseeing कि अब ना 2 weeks के बाद तो मैं बंद ही करने वाली हूँ, मतलब I'm not giving the biologic any further, then you might say कि just let's wait for 2 weeks and then we would give. Otherwise, there is no contraindication for giving vaccination in patients who are on treatment with immunosuppressives.
Okay. Dr. Kasla is asking that if there's in a case of Kawasaki's with cardiac aneurysm, how frequently do we follow up to the echo?
So the first echo, of course, when you're diagnosing, then pre-discharge, then 2 weeks, then 6 weeks. Then the amount of aneurysm guides you to how frequently you follow up. Usually 6 monthly follow-up is required in these patients.
Okay. Fine. I think there are no more questions on Kawasaki's disease. So we move on to our next, which is Henoch-Schönlein purpura or IgA vasculitis. Here we wanted to know that do we need to biopsy these patients for diagnosis, or is the diagnosis more or less only clinical?
It is a clinical diagnosis. So even the even the diagnostic criteria doesn't say you that you need to biopsy to prove a leukocytoclastic vasculitis or IgA deposition for Henoch-Schönlein purpura or IgA vasculitis. So not compulsory to biopsy.
What are the indications to give steroids in children with HSP?
So for IgA vasculitis, these steroids are given. So it's not all patients who need steroid because in the pediatric age group, they usually fare very well. So only if you see that there is a significant GI bleed. So if there is a significant, if you see the stool focal blood, the patient is wincing in pain because of the abdominal pain, the mesenteric vasculitis that happened. That is one indication where you give steroid to these patients. Sometimes for arthritis, if there is very significant arthritis, which is not responding to the NSAID which you have given, then you may tend to give these patients a short course of steroid. As such, it is a short course of steroid. Or if there is pulmonary bleed or child is significantly sick, then you will give steroid. Otherwise not. So normal HSP, if you see just a skin rash, just mild abdominal pain, nothing which is settling in a few minutes or something like that, then you would not give steroid to this patient.
And it would be a short course and tapered off.
Yes. So total 4 to 6 weeks. And first 2 weeks, it's 1 mkd and then taper it off in next 4 weeks.
And what is the NSAID that you prefer in all these patients with arthritis?
Yeah, your network is sketchy. So NSAID is what you're asking, right?
Which NSAID, which is the NSAID that you prefer?
So naproxen and ibuprofen, both are good. Maybe personally, I prefer more naproxen than ibuprofen. The response of both has been seen to be equal only.
Is there an age-wise safety factor for NSAIDs?
Not that what I know of, because we have been prescribing left naproxen is like very frequently. So I don't think so that there is an age wise. Agar zyada hi chota hai, then might be prefer ibuprofen, but otherwise we give it. Yes, if there is certain patients of enthesitis related arthritis, indomethacin is a good, very good NSAID for these patients who have axial disease. So these patients we may tend to use indomethacin.
These are relatively older patients, right? The enthesitis.
Older patients.
And they will always have the sacroiliac joint inflammation.
No. So enthesitis related arthritis, that's the difference between an adult and spons. So they may not have the sacroiliac, and they may just peripheral arthritis may be there in the juvenile variety. But if they have an axial disease, what I have a personal experience is the indomethacin works much better in these patients.
Right. Okay. Coming to SLE, lupus. So here, systemic onset GIA, which may have initially fever, rash. Lupus may not always typically have the typical malar rash that we, kind of see in textbooks. How do you clinically try to distinguish between systemic onset GIA and lupus? And whether we always find those typical, we have those criteria, the criteria for malar rash, discoid rash and all. So in clinical practice, how do we use those criteria to diagnose?
So one is first question, systemic GI and SLE. They are very different disorders, Dr. Jagruti. So normally systemic GI will have very high grade fever of 2 weeks or 3 weeks only. And then they will have that different kind of a rash. Even if they don't have, if they have an evanescent kind of a rash. The SLE variety jo hai fever, that will be a slow smoldering fever going on for around 1.5 to 2 months. And the child will gradually be getting sick compared to systemic onset. So I don't think so. There is a very big confusion between SLE and systemic onset GI. Yes, there is always confusion with leukemia. So this is what SLE will present. There will be, mother will tell you a history ki nahi bacha पिछले 15 दिन से I am feeling ki no, the child is not normal, getting more lethargic whenever she comes from school or something like that. There will be a history of hair fall. There might be malar rash, there might be oral ulcers, but not sacrosanct, and they might have joint pains, like the arthralgia variety where we were discussing initially. So they might have joint pains in the body, this lupus variety. What was your second question? The SLIC criteria. So the SLIC criteria, these are classification. They are not diagnostic criteria. And if you actually read the SLIC criteria, na, I think so many patients can fit into the SLIC criteria. Right. Because it is fever hai, rash hai, and then ANA positive aa gaya hai, so you can diagnose lupus actually. SLIC criteria. So these are all classification criteria. The diagnosis is always clinical with lupus and lab supported. So if the immunological profile, what you do, if you see an ANA which is homogeneous or speckled pattern, and then you do a blot which you see dsDNA is positive, complements are low, or Smith is positive, or any other antibody which is specific to SLE is positive, then you diagnose them as lupus.
Okay. Dr. Amruta has asked one question on HSP, the type of joint involvement in HSP.
Usually large joint involvement. They do not injure the joint, like we say in rheumatic disease also, like they lick the joint, they do not cause any chronicity in the joint. So they will respond very easily to the NSAIDs, they will become better. Very, very rarely steroid uses, that is also associated GI symptoms or something like that, then we use it. Usually large joint.
Dr. Reepa Agarwal is asking that we have an HIV positive 11-year-old girl with disseminated COX and SLE with worsening of TB. Now she has developed psoas abscess on low dose prednisolone once a day and hydrochloroquine, it's CQs. How to monitor SLE activity in such patients? And when do you consider other steroid sparing agents?
So I'll read it again. I've gone to the chat box. So HIV positive, disseminated COX, and lupus. So one, you have to tell me whether the lupus is secondary, matlab antihistone positive antibody, which has been caused because of a drug-induced lupus. So I consider she's not mentioned drug-induced lupus, matlab it is a proven lupus, which is dsDNA positive, with worsening of TB, now develops psoas abscess and on low dose prednisolone and HCQS. So monitor the activity of lupus complement levels and anti-dsDNA. So none like disseminated COX also or HIV will not cause an anti-dsDNA positivity. Okay, immunosuppressed, so complement level. C3, C4 will be low if the disease is in active stage with lupus. And when do you consider other steroids? For every lupus, steroid is not the treatment. Steroid is just to tide over. They have to be on a steroid. Whenever, for whatever you start steroid, for XYZ disease, for asthma also, when we start steroid, we know we are stopping it at 5 days. We cannot give unmonitored steroid. That is one thing very sure. If anybody is good taking home message, this is one very important thing. No unmonitored steroid. You need to know that you are stopping it in this time. For HSP, we know we will stop it in 6 to 8 weeks or 4 to 6 weeks. If we know we need an immunosuppression for long term, that time when we're starting steroid, that time itself we start a steroid sparing agent. So of course, steroid sparing agent, which one to choose will be guided by a lot of things. So in Dr. Ripa's case, I think we'll have to have a personal discussion about this case, because whether the LFTs are okay or not, HIV, whether the child is in, what kind of a CD4 levels the child is having, the CD count kaisa hai uska, CD4, CD8 levels. So all these things will make us take a decision, because T cell immunosuppression se better B cell immunosuppression rahega kya? All these you have to consider in this patient.
Are there any common pediatrics, the drugs that we use, which can cause drug-induced lupus that we should be careful about?
Anti-TB drugs are the commonest ones which might cause. Then a lot of antipsychotic drugs and all those can also cause. That is the reason I asked this question, because in case of post-TB or medications causing it, antihistone would be positive and dsDNA would be negative in these patients.
Right. Dr.
For
Kasla.
her, I think yes, please go ahead.
No, sorry, go on.
So that's what I was saying. Best thing is to monitor the complement levels.
Complement levels. Okay. Dr. Kasla is asking, how do you differentiate between arthritis and enthesitis?
So enthesitis is, this is joint, end of the joint when you touch na, like we have tendoachilis, typical tendoachilis ko touch karenge, to wahan pe pain hoga. So that is enthesitis. Enthesitis is where the ligaments and the tendons go and attach to the joint or the bone. That points are painful. Arthritis, enthesitis may not show you any swelling of a joint or something. Arthritis means there will be a diffuse swelling, range of movements will get affected, but not like a point tenderness. It's more of a diffuse pain.
Coming to neonatal lupus rash, what we see, so many times patients could, like this usually could be seen after the first couple of weeks is what I understand. And that's also the time that you could have patients of atopic dermatitis who develop a similar kind of a rash. Now, how do you differentiate between the two? Do you actually check for the, bradycardia and the, heart-related effects that we see with neonatal lupus? What is the history in the mother that we need to look for? And how do we go about with such a patient? I mean, we see so many more patients of atopic dermatitis and we don't bother to actually, I mean, of course, we must be all checking for heart rates and all as a part of our regular examination, but is there something that we could be missing?
So no, I think atopic dermatitis, one thing which I know there's more of extensor surface also involved in a child when there is an atopic dermatitis, and the child will be more irritated with atopic dermatitis if there is an itch associated with it. One is that. Second is for the heart rate, when the gynecologist also will call you that the heart rate of the baby doesn't seem to be okay. For the mother, first thing is neonatal lupus is a big misnomer because the mother doesn't have lupus. mother may not have lupus or usually doesn't have lupus. What the mother might be completely asymptomatic, or he might have a Sjogren syndrome with a ROLA being positive, anti-ROLA being positive, where you monitor very closely the baby to have it. Sometimes it's just de novo, mother doesn't know that she has a disease. You get to know that there is a cardiac involvement or there is a heart rate which is the low in the baby, there is a block, there is there. And then you investigate the mother for ROLA antibodies and you see whether she is having a disease, treat her accordingly. That's a separate thing. For the baby, only the cardiac condition guides us to therapy. Otherwise, with neonatal lupus, if you do a CBC and if the counts are all normal, they don't need therapy.
Okay. Fine. So coming to JDM, that is juvenile dermatomyositis, one question is that do the skin and the muscle present simultaneously, or sometimes you could just have like, a progression from one to another?
So it can be both ways. It can be no progression also. It can be a patient who has no skin manifestations, has minimal skin manifestations. Like we always think कि Gotrons hona chahiye and heliotrope rash hona chahiye and facial malar rash hona chahiye. So like lupus, they may not have. So sin dermatological manifestations or sin muscle manifestations, both can have, we can diagnose as dermatomyositis. And it can also be one after the other. So the weakness usually starts earlier. Usually when we see the weakness will start, and then the child will have started developing the skin manifestation, the rash as well. And that is the point where you consider that you might be dealing with something which is an autoimmune disease.
So here, like, as a part of treatment that we would start steroids, even steroids in the long run will cause proximal myopathy. So how do you differentiate? Like suppose there's a patient of JDM on steroids and the myopathy is like not getting better because probably he's developing a steroid-induced myopathy. How do you differentiate between the two? Do you put the child on a steroid-sparing agent?
Again, I said, all JDMs need a steroid-sparing agent. Now, to in fact, the recent recommendation on guidelines in rheumatology, all our recommendations, the steroid in their dosage is lowest possible dose for the shortest possible duration that you need to use. That is what is recommended for JDM, for lupus, for everything. So we always put them on a steroid sparing. We know these are autoimmune disease. These will need long-term treatment. They will need a steroid sparing agent depending on the disease diagnosis. The steroid-induced myopathy, that is the reason, is tending to be less. So if what we see, if we do not give a very high dose and very long-term steroid. So these are myopathy, so not myositis. So there will be no signs of, if you do an MR, the flare intensity that we see with myositis will not be seen with steroid-induced myopathy.
So which is the drug of choice that is used now with JDMs?
You are asking the DMARDs? Methotrexate. So if it is juvenile dermatomyositis, the first thing that we use is methotrexate.
And what do you monitor when a child is on methotrexate?
Again, the same things. So so there is a bone marrow suppression. So you'll do a CBC. For monitoring of the disease activity, you might do a ESR here to see whether it is normalizing or not. And a liver thing and a kidney thing. So maybe SGPT and serum creatinine.
Fine.
Something very important, what I feel, is sunscreen in all these patients.
Yeah.
So all patients who are any positive, you should always advise them a sunscreen.
Any particular sunscreens that you would advise, any particular SPF factor?
More than 30. That's it. No brand specific, of course. More than 30 is good. And then you have to remember that you need to supplement them with calcium and vitamin D because you're giving a sunscreen.
Okay. We are coming to a close as far as it's like, we have very little time in the whole world of rheumatology to discuss with Dr. Sikha. But there's one very common thing that we as pediatricians see in practice is growing pains, restless leg syndromes. So can you guide us as to how do you how would you differentiate between the two and what would you treat them with?
Growing pain, of course, no treatment is required. To be very frank, sometimes it's too much, then we tend to give a prophylactic dose of vitamin D and calcium. If at all you see that the mother is really worried about the pains that the child is having in the evening time. Restless leg syndrome, I don't think so. I see too much of a restless leg. So you always see whether the electrolytes is okay or not. Anemia is a very important thing which we consider when there is a restless leg syndrome. So you always see if the child is anemic, you treat with iron, the child will be better. If the child is B12 deficient, For anybody, I had a lot of restless leg syndrome because I was B12 deficient. So that is one thing which you see. If there is a B12 deficiency, any vitamin deficiency, I think can cause a restless leg.
I think, in one of the conferences I attended, they said serum ferritin is one of the things that can guide us for restless leg. And if it is low, then you put the patient on, say, 3 to 6 months of iron therapy and the treatment. The restless leg syndrome, the presentation or the symptoms might go down. So I think it is aligning with what you are saying here. Dr. Bharti is asking, when will you do myositis specific antibodies and myositis associated antibodies in JDM?
In all, basically, it's a very costly test, costs approximately 7 to 8,000. But sometimes this NX, supposedly, if I see a patient who is sick, JDM, and the NXP2 comes positive, then I know that I need to monitor more closely because it's a severe disease. If the MDA5 comes positive, I need to monitor the lungs to see whether it's developing an interstitial lung disease. So if it is at all possible, then I tend to do it. Depending on the, of course, possibility, how much the patient can spend.
Okay, Dr. Deepa had asked a question earlier on that if I have a patient of chronic urticaria, what are the autoimmune causes that I must think of and what tests should we do?
Again, Dr. Deepa is asking wide range of questions. So chronic urticarial vasculitis is one of the things which is there, but we have to remember these urticarial vasculitis do not have urticarial itch. They are more like burning sensation. Sometimes we just tend to diagnose कि इसको बहुत बार wheals आ रहे हैं. So recently 2 days back I saw a patient wheals आ रहे हैं, बहुत itching है. Can it be urticarial vasculitis? No, that patient is not urticarial vasculitis. So with chronic urticaria, one thing is common is this one. There are other immunodeficiency disorders like Job syndrome, where there is a hyper IgE and they can have chronic itch and they're not gaining weight, and they can have small staphylococcal infections as well. That can cause chronic urticaria kind of illness. Then there is initially what we used to call Church-Strauss syndrome, where there can be more episodes of asthma which are not getting treated along with urticaria, then skin lesions or something like that, that we can consider. So there are a lot of other things we can consider. If she's asking specifically of urticarial vasculitis, very rare disorder, not very common. So think if the child is having urticarial lesions without itch, more of burning sensation, then usually you do biopsy of those lesions.
Okay. Fine. I think I have covered everything that was there in the chat box till now. And now we have a surprise from Dr. Sikha. She's going to basically put up some spotters of this. Shikha, will you be able to share your presentation? Just check it. In the meantime, Dr. Kasla is asking which common infections can cause reactive arthritis. Are you able to share or should we?
So any viral infections can.
Yes, we can see. I think.
Slideshow is seen?
Yes, Shikha.
Can you hear me?
Yes, Shikha.
But I think I can see only my screen. Now you'll have to guide me because I can't see anybody else in the chat box or anything. I'll just change the screen and then people, it is just spotter. If people are putting in the chat box the answer, that will be like really good.
Okay, great.
So this patient, the patient is around 8 to 9 years girl child who is presenting with this. If I tell the symptoms, you will tell the diagnosis. Joint involvement, multiple joint involvement.
Yeah.
So I think we will go on quickly. This is what we initially used to classify as polyarticular JIA, and what now we can classify as either other JIA or RF positive JIA. So this child was RF positive.
Okay.
RF positive JIA. Okay.
Yeah. Next one.
So this child with a very high fever going on for 5 to 6 days, small child, around 1 year old child who has developed a rash also, and then there is this when you examine the child.
We have a lot of answers saying Kawasaki.
Yes. So perianal peeling in the first week. So normally the other desquamation we say na tab tak to bacche ko matlab it's the end of second week that we see. This we will see in the initial stage. And this is not something which is associated with diarrhea-like rash. This is not a typical diarrhea-like rash. It is a perianal peeling which might be associated with Kawasaki disease. And then this is a child who is spiking high fever, and then if you can see the rash here.
It's not well appreciated. Can you just describe the rash? Yeah, okay.
So it's an evanescent rash. I don't know why is my slide not working now. Can you see this?
Yes. Dr. Namrata has written systemic JIA.
Yes, systemic JIA. So this is the rash, evanescent rash once I say. So the chances of systemic JIA, and the child is usually very normal in between and all okay kind of a child.
Right.
Okay. To the next. This is a child who has prolonged fever and this kind of rash. Slight amount of weakness is there and around 1.5 months of
There are two answers. One is SLE, another is HSP.
So SLE is the diagnosis for this child. HSP rash, we have to remember that these are palpable purpura-like rash, more red rash and on the dependent areas. So usually it will be lower limbs. They can occur in the ear lobule when the child is sleeping to one side, then they can occur in the ear lobule as well. But usually face is not that is involved with an HSP-like rash. Okay.
But this is not a typical malar rash. This is more over the forehead in this child, right?
Rash, why I put this was I could have put a malar rash also, but the SLE rash is so much. It will be no rash to any rash kind of stuff.
Okay. This is Gotron papules, JDM. We've got
Yes.
answers saying JDM.
Yes, so this is Gotron's papule, JDM. But again, to say that sometimes if Gotrons are not there, we tend to not diagnose juvenile myositis. So I have a patient who has landed up in calcinosis because it was diagnosed very late. So just because a child did not have Gotrons. So this is not sacrosanct. But of course, if it is there, it is clearly indicated that there is this.
How do you treat calcinosis in... Okay, so this is calcinosis?
No, this is not. I didn't put the calcinosis one. So calcinosis, very difficult to treat. And till the child is JDM only, we always say theek ho jayegi, theek ho jayegi. As soon as we see the first patient was like calcinosis ka first lesion, we say ki now it is difficult. So it may go into stagnant phase, stop it, but we usually give calcium channel blockers or bisphosphonates for that. But the morbidity might be very high. Not mortality, but morbidity. If it's across joints, may cause mobility problems.
Okay. There are no answers on this as yet, Shikha. No, the previous one, the one with the X-ray.
This is not working according to what I wanted to. Wait, huh? Seen, right?
Yeah, this is seen.
So this is a child over this is I think around 3 years child. Over last 2 years, the child is having one single limb involvement. Gradually, it started with one patch and now you can see the limb has almost shrunk. So this is actually a scleroderma, pansclerotic morphia. Yes, so it progressed because I put an MR. I'm not being able to use my pointer. I don't know why today. So she had very significant lymph nodes. The MR was done considering why is there a joint restriction. The lymph nodes was identified. Lymph node biopsy was done, but a skin biopsy was not done in this patient just to identify scleroderma. Lymph node biopsy because the MR finding suggested round cell neoplasm. Yeah, but if you see now, if you see the skin here, you can see the edema that you can see. The MR may, the skin part, if you can see, there is a edema.
Yes.
This is again very easy diagnosis. So this is what is scleroderma. You just pinch the skin. You cannot pinch the skin means the skin is tightened, and then the chances of scleroderma is there.
Right.
Small child, very with fever, on treatment with, of course, somewhere outside she goes on treatment with medications. Shall I?
नहीं आंसर नहीं आ रहे.
It is some drug which has caused this.
Phenytoin.
So phenytoin is a very good guess, but I don't use phenytoin. This is cyclosporin.
This is
Cyclosporin.
cyclosporin.
Significant gum hyperplasia. Phenytoin was a very good, it can also cause this gum hyperplasia actually. But this was cyclosporin which caused this patient. This one, we stopped it. The child is absolutely well off steroid on methotrexate now, and all this has disappeared. They have come off.
Wow.
This is it? No diagnosis.
We can see it.
No guesses for this?
No.
Joint contractures, multiple joint involvement, the elbow, the wrist, the small joints of the hands. Lateral.
Polyarticular, GIA.
That's the reason I put this, because this is actually congenital contractural erectodactyly. So I thought I'll put one case, because in rheumatology, it's not always what you see. It's not always what meets the eye.
Okay. Yeah, thanks, Dr. Sikha. And I think there are no more questions in the chat box. As
Am
you
I there
rightly
still?
said that the eyes
Second,
can see only what the
share.
mind knows. So that was a very wonderful quote to end your session with, Dr. Sikha. And we all, I think, like considering all of us are in some or the other zone of IIP Mumbai, we must have read Dr. Sikha's poem on GIA. If you could just read out a couple of lines, Dr. Sikha, to end this beautiful session with you, it would be really very great. Dr. Sikha has written a poem for her patients of GIA, and it's a very beautiful poem.
It's a very long
You could
one,
just
I think.
probably read the
Since you
last few
messaged me, I
lines.
took that out, but I think it's a very long. So
Read the
last
last
few
para.
lines.
Just the last para.
Last para.
Okay. Okay, so last para says a few weeks on and the child does better with the symptoms reduced to just a few. A smiling child endorses me, doctor, thank you. Encouraging me to keep my job doing. That's what during tough times keeps me going.
So thank you, Dr. Sikha, for a very wonderful session, and especially all the photos that you put up in the end. That made the whole session even more interesting. Thank you to the viewers for joining in such large numbers and also asking a lot of questions. And thank you to IIP Mumbai for making our monthly meets so very interesting. So over to you, Dr. Nehal.
So, of course, thank you, Dr. Sikha, as an expert, and Jagruti as a moderator to make this session very informative and interesting. And yes, I think everybody who's attended Sikha's online or offline physical CMEs knows that spotters and a visual curtain is so pathognomic of Sikha's presentations that adds the charm to the entire presentation. So, yes, thank you very much. And thank you all the members for joining. And the April Webflix episode 3 of this year is going to be on skin. And it is really going to be very interesting to look at the various common skin conditions that we are seeing in daily OPDs and how do we deal with these, how do we diagnose, and how do we treat. So stay tuned with us, and thank you once again, the experts, moderator, and all of you for joining in today. Good
Thank you
night
so
to
much,
all of
madam.
you. Good night.
Good night.
Yeah, good night. Good night.